think everybody is on. Can you guys hear me okay?
Mm-hmm.
I muted you all, so I guess I can't hear you respond.
Yes, I can hear you.
Okay. All right, so this initially was going to be a really small group, and then I had quite a few people add today. So previously I've had sort of like a helper to help me monitor questions in the chat box. So I'll encourage you to use that throughout the presentation, and feel free to unmute yourself and shout out at me if I miss your question. Sometimes I forget to check over there while I'm discussing. So my name is Amber Spring. I'm a counselor at MSU Northern, and I'm also the chair of the Hill County Suicide Awareness Coalition. And we elected to buy several of the online training modules for QPR during Suicide Awareness Month in September, and we still have quite a few of those left. So I'm just wanted to express appreciation to that group for sponsoring our training. Everything that I share with you today is available on Carl Roston's website. He's the suicide prevention coordinator for the state of Montana, and I will give you guys a link to all of the statistics and those things that I'll be discussing today if you need those in the future. I don't know if everybody had time to do the pre-test. If you didn't, it's okay. The link that the QPR Institute sent you is where you will go to complete your post-test after the training, and you'll also be able to download your certificate there as well. QPR is sort of similar to CPR in that your certification is good for 3 years. This COVID-19, I guess some of the positive sides of that is that it's allowed us to do some of these online trainings that used to only be allowed to do face-to-face. So the resources that we usually hand out in the face-to-face trainings are also available for you in an e-format, and you'll have access to those on the QPR Institute's website as well. Getting your certificate or anything like that, just email me and I'll see if we can get things figured out for you. So today I'll be going over a lot of facts and figures and kind of talking a lot. So I'll apologize for that in advance, but I think there's a lot of really good information packed into this, especially if you're a person who's not really familiar with the way that depression and suicide affects our state. So I'll start with this quote. "Depression is such a cruel punishment. There are no fevers, no rashes, no blood tests to send people scurrying into concern, just the slow erosion of self, as insidious as cancer. And like cancer, it is essentially a solitary experience, a room in hell with only your name on the door." And this quote comes from a woman who is both a clinical psychology professor as well as a person who herself has dealt with depression and had cancer as well. And I think this is kind of although sad, kind of an accurate impression of what depression is. So today, like I stated earlier, I'll be sharing a lot of information from the Montana Suicide Prevention Coordinator, which includes our suicide data, which is specific to the state of Montana, information about depression, some warning signs of suicide, factors that you might be able to utilize to assess a person's risk, as well as risk factors in general, and protective factors. And then we'll move in to the actual QPR training, where I will talk about some suicide myths and facts, suicide clues and warning signs, and then the QPR acronym, which is tips for asking the suicide question, how to persuade someone to stay alive, and how to refer someone to get help. So when we look at suicide in general, in 2017, we had 47,173 suicides in the United States, which amounts to 129 suicides per day, or one suicide every 11 minutes. Males complete suicide at a rate of 4 times that of females. However, females attempt suicide 3 times more often than males. And the next statistic kind of alludes to the differentiation in those numbers. Firearms are the most commonly used suicide method, accounting for nearly 51% of completed suicides. And because men typically choose a more deathly mean for suicide, that is why the rate of their suicides are higher than females. Some of you may have filled out a depression assessment when you visit your primary care provider. And one of the reasons that a lot of primary care providers are assessing that information is that we know that 45% of individuals who die by suicide have visited their primary care provider within a month of their death. And 20% of those individuals have actually visited their primary care provider within the last 24 hours before their death. So oftentimes we are seeing that people are accessing primary care more frequently than they would be mental health. So therefore, it's important for us to be assessing that in the primary care setting as well. We know that there is a strong correlation between chronic pain and suicide. And in fact, 20 to 30% of those who die by suicide have issues of chronic illness or pain. And a person with chronic pain is at 3 times the risk to die from suicide. I know we have several teachers, K through 12 teachers on this training. So some of this information may pertain to you, and if you have questions, just let me know. In 2017, there were 522 children between the ages of 5 and 14 who completed suicide in the United States. The youngest was an 8-year-old. Suicide rates for those between the ages of 5 to 14 have increased 60% between 1981 and 2010. And I actually, this morning on the news, they were talking about the changes in mental health with COVID-19. And one of the things that they talked about is the increase in suicidal ideation that they're seeing even in children. Just some really sad effects from that. Suicide is the second leading cause of death among people 15 to 24 years old. And only accidents occur more frequently. In 2017, there were 6,252 suicides by people between the ages of 15 and 24 years old. People within that age range, their suicide rates increased more than 200% from the 1950s to the 1990s. They went up again in the early 2000s. For those of you that work with teenagers, I think this is an interesting thing to keep in mind. Most adolescent suicide attempts are precipitated by interpersonal conflicts, and the intent of the behavior appears to be to affect change in the behaviors or attitudes of others. So we'll see things like, whether that be conflicts between the teenager and their parent, or their significant other, or their friend group, or a coach, or something like that. But we're seeing those interpersonal conflicts really be related to their suicide attempt. So this month is LGBTQ History Month, and I really wanted to highlight the disparities that we see in mental health with LGBTQ. 40% of LGBTQ respondents to the national survey on youth mental health indicated that they had seriously considered attempting suicide in the past 12 months. And more than half of transgender and non-binary youth have seriously considered suicide. LGBTQ youth are 4 times more likely, and questioning youth are 3 times more likely to attempt suicide as their heteronormative peers. And this is something that I think is important for us to think about too, is that LGBTQ youth who come from highly rejecting families are at 8 times the risk of having attempted suicide as their LGBT peers who had reported no or low levels of family rejection. So again, that kind of goes back to what we talked about in the previous slide. Those interpersonal conflicts and those relational issues are obviously large factors in attempted suicide. Another thing is that the usage of a chosen name by a person who is trans resulted in a 29% decrease in their suicidal ideation and a 56% decrease in suicidal behavior. So this is something that seems probably pretty small, but really changes, the way that person is assessing things in their lives. Again, for those of you who are our teachers, I read that often people who are trans are only out to one adult in their life, and a lot of times it is a person in their school system. So I think just acknowledging that you can really play an important role in that person's life, and obviously have some profound effects on their suicidal ideation. So when we look at college students, it's estimated that there are more than 1,100 suicides on college campuses per year, making it the second leading cause of death for college students. And it's estimated that there are 24,000 suicide attempts occurring annually amongst college students between the ages of 18 and 24. There's a pretty famous program where they bring in 1,100 backpacks, and they all have personal stories of college students who have taken their lives that are attached to each backpack. It has a picture of the individual as well as, where they were at in school and that kind of thing. And it just really takes it. I've seen that campaign when I was a graduate student at MSU Bozeman, and it's really, I think, just shocking to see those 1,100 backpacks sitting there and thinking about, that every year that's how many suicides we see with college students. An interesting thing, though, when we talk about suicide amongst college students is that college seems to be a protective factor, and that students who are enrolled in college are less likely to have suicidal ideation or suicidal attempts than their peers. Does anyone have thoughts about why that might be? Feel free to unmute yourself if you want to talk, or you can also type things in the chat box.
So I think one thing that really contributes to suicide is not interacting with other people. So when you're in a college setting, you're interacting with other people on a daily basis, and social activities tend to help prevent suicide ideation, for instance.
Absolutely. Yeah. And I'm seeing Lisa says isolation, and Susan says a sense of belonging to something bigger. All of those things are very true. So if you think about, and sadly, this is one of the negative effects that we have seen from COVID-19 is we haven't had as much interaction with our students, and that's both at the college level as well as the K through 12 system level. But that interaction that we're seeing people daily, whether that be our peers or people in our classes or our staff and faculty, and that sense of belonging to something bigger is another thing that is big for college students too. So another thing that we talk about in terms of risk factors with suicide is that often people are not having thoughts about the future. There's often a sense of hopelessness and those kinds of things. And so what we see oftentimes with college students is that they have a plan for their future. They're typically in college working towards some futuristic goals. And so that futuristic thinking is strong for them, which again tends to be a protective factor. The other thing I think about is that we also, we teach a lot of resource seeking and those kinds of things in the college system too. So my hope is that college students also, and I say this probably selfishly as a college counselor, but my hope also is that college students are better able to access services or those kinds of things, whereas students that adults their age that are just out in the working world might not have as much access to those kinds of things. So another population that we talk about a lot with suicide is our veterans. An average of 20 veterans die from suicide each day, and only 6 of the 20 were actually engaged in VA services. So we know that veterans account for about 18% of all the deaths from suicide among U.S. adults, whereas they only make up about 8.5% of our population. So obviously, a lot more frequency with our veterans. Approximately 65% of veterans who die from suicide were over the age of 50. Another population we look at often is the elderly. In 2017, 8,568 Americans over the age of 65 died by suicide. Interestingly, the rate of suicide for women typically stabilizes after the age of 64. For women, it usually peaks during middle adulthood, between the ages of 50 and 54. Whereas 85% of elderly suicides were male. So the rate of male suicides in late life was 7 times greater than for female suicides. And if you think of the reasoning behind that, one is what I alluded to earlier, in that men tend to choose more lethal means for suicide. But the other thing, I think, and I don't think this is discussed further in the presentation, I apologize if it is, but another thing that we see with elderly males is they typically don't have as much of a sense of purpose and meaning once they are retired and that kind of thing. I think just in terms of gender roles, a lot of times men feel, a lot of identity and those kinds of things kind of tied to their profession. It's not to say that women don't either, but I think a lot of times women are still socially connected with other women, with their family, with their grandchildren in ways that also gives them a sense of purpose, whereas that's a little bit more challenging, I think, for men at times. Hopefully something that we work on changing in the future, but certainly things that affect them at this present time. So when we look at suicide in the state of Montana, most of you are probably aware that Montana has ranked in the top 5 for suicide rates in the nation for the past 40 years. So as long as we have been tracking suicide data, Montana has been in the top 5. According to the CDC, Montana is no longer the highest in the nation, which we were a couple of years ago. We are now ranked 3rd, according to the most recent data, which puts us behind New Mexico and Wyoming, and Alaska is the 5th. I don't know why I don't have who's 4th on there. Mexico, Wyoming, Alaska. I'll have to look and see what that one is. I don't know why I left that out. Carl Rustin is the suicide prevention coordinator for our state, and he attributes the drop that we have recently seen in our rates to those positive changes in efforts that we have really made. Some of you may be familiar with the PAC's Good Behavior Game expansion in schools. That is an evidence-based program that has really showed to improve children's ability to regulate their emotions, which has long-term effects for them in terms of going into adulthood. We are also seeing more integrative behavioral health care in rural areas. And that's really been a movement that's been recent. For those of us who live here in Havre, our community health center, for instance, has added mental health services when they expanded to their new building. And we're seeing that in a lot of rural areas. And in fact, there's a lot of federal funding for our small rural facilities to add behavioral health and mental health services. You might notice that I use these words I don't know that I'm using them consistently, but when we talk about mental health, we're primarily talking about things like depression and bipolar disorder and things like that. When we talk about behavioral health, it's including substance use and abuse disorders. I'm trying in my brain to switch over to that word, but sometimes you'll hear me still say mental health. Oh, the other thing I didn't mention there is another reason he thinks that the rates are decreasing is because we've had such a high utilization of the suicide prevention lifeline. That has just been really marketed a lot in our state. And in fact, them also adding the ability to text to a crisis counselor has definitely increased the usage of some of our younger Montanans. So when we look at this map, this was from 2017. So this is the suicide rates for the U.S. states. And those that are in red are the ones with the highest rates. I asked this in the last presentation. What do you notice about this? And one person was like, well, they're all red. So we're kind of in that red-blue mentality, I think, right now with it being an election year, but they're just red to show that the rates are high. What things do you guys think do these states all have in common that would potentially lead to them having higher suicide rates? Again, you guys can unmute yourselves or post in the chat box.
Smaller populations, more rural areas.
Yep. Rural, smaller population, which then means we have, less contact.
Are these also poorer states?
What did you say? Border states?
Poorer, less
States,
wealthy.
Absolutely. So lower socioeconomic status for sure. More distance to travel for help. Yeah, not as much accessibility to services.
I would also say in the northern states, maybe lack of sunlight in the wintertime, that seasonal depression.
Yep, absolutely. So yeah, we see a lot of things we talk about, like, no matter how much time you're spending outside, there's no way for us in the state of Montana to be able to get enough vitamin D naturally. Like, all of us should be taking a supplement. I'm not a doctor, so I guess I should give that disclaimer. But the other thing is, do you guys notice anything geographically besides kind of how a lot of them are in the northern region of our country?
Is it just higher altitude? Are they more higher in the Rocky Mountains?
Yes. So higher altitude, and we'll talk about this. This was the first time I saw this presentation. This was one thing that I was like, wow, we never learned about that in graduate school. So yeah, what we're finding is that that this line of states is obviously where the Rocky Mountain range is. And we are seeing that the suicide rates are higher in areas where there's a higher altitude. And I'll talk about that a little bit in the next slide. Anything else when you think about these states and maybe what their value systems are or that kind of thing? Do you think there are any other similarities that might lead to higher rates of suicide?
I would maybe add, since it's in the Rocky Mountains, there's pretty extreme weather patterns. Mm-hmm. So that can lead to people just staying inside, developing like substance abuse problems that then result in suicidal ideations.
Yeah, so I'm hearing you say probably more substance use and also maybe some social isolation.
I would also say that in the Western states, we tend to have a just sort of a pull yourself up by the bootstraps type of mentality. Just that mental health is probably considered, for sissies or mental health services.
Absolutely. We absolutely have that. I mean, this is kind of the cowboy culture, right? Like, I don't need to ask for help. I'll figure it out myself. It's really not that bad. Or the sense of like feeling weak if you can't do those things on your own, if you were to need some professional help or something outside of that. So yeah, absolutely. Anything else? I'll move on to the next slide and the next couple of slides. So when we talk about having a high rate of suicide in the state of Montana, it's not just one factor, but rather it's multiple factors. And all of those things are affecting us all at the same time. And I think it was Susan that commented last. It is a cultural issue. It has a lot to do with the values and the culture that we have within our state. So vitamin D deficiency, we talked a little bit about that as being a reason. We know that that's correlated with an increased risk of depression. And I will just say sort of anecdotally, I know for our psychiatric nurse practitioners who work in our community, that is one thing that they will want to have assessed a lot of times before they will even see someone for medication, is really to look at what their vitamin D deficiency looks like, because sometimes for people when they get back what to a level they should be at, we see a decrease in their depression symptoms. The other thing we talked about earlier is where there are pockets of populations that are more highly affected by depression than others. And we have a high concentration of many of those. So we have more veterans in the state of Montana, we have more American Indians, and we have more middle-aged white men, all of which are we see higher rates of depression with. And somebody mentioned this, I think it was Chris, and alcohol being a coping strategy. So oftentimes we are seeing that there was alcohol in the person's blood when they took their life. And that rate is 2 times the national average. We also, again, going back to that sort of cowboy states, we have more access to lethal means. We know that 65% of suicides are typically from firearms nationally. In the state of Montana, we see that rise to 90%. So something really to be thinking about. Stigma, I think Susan mentioned this. We see depression as a weakness, that we're a burden, and obviously if you think you're a burden, how likely are you going to be to ask for help? We talked about this earlier in terms of what all of those states had in common, in that we don't have a lot of psychiatrists or mental health providers in our state, although we are working on increasing integrated behavioral health into our primary care. That isn't always available. Someone mentioned socioeconomic status. I think that was Casey. So we're seeing about 1 in 5 Montana kids that are living at more than 100% below the federal poverty level. So if you think about all the factors that living at a lower socioeconomic status might have on a person's mental health, obviously that's a contributor. And this is the one that has to do with the altitude. And this is really interesting, but it makes a lot of sense. So what we're seeing is at a metabolic level. So the metabolic stress that is caused by long-term oxygen deprivation is a contributor to depression and ultimately to suicide. So this isn't just in the United States, across the world. What we are seeing is that people who live above 2,500 feet, we see a spike in suicide rates. And here in the state of Montana, the average suicide occurs at 3,500 feet. And then we've talked about this several times, just that social isolation. We joke sometimes that Montana has more cows than people. I don't know if that's still true, but we only have 6.7 people per square mile, whereas nationally there are 88.7 people per square mile. So we're just really, isolated. And I think, I'm not trying to turn this into a COVID-19 discussion by any stretch of the imagination, but I think about all of these things that we are seeing on this slide here and how those might also be contributing to what we're seeing right now. So we are seeing more social isolation nationally. We're seeing changes in our socioeconomic status in terms of the people being out of work and businesses not being able to run in the way that they're used to. We're going into winter where we all experience more vitamin D deficiency. A lot of times when in isolation and when coping with life stressors, people do use substances as a coping strategy. And then there's some stigma, I think, in that too. A lot of the reading that I've been doing as a mental health provider around COVID-19 is to really make sure that we're discussing how we're all in this together. Like, people are experiencing this across the board. There doesn't seem to be people that haven't been affected by this. So hopefully that's a way for us to sort of help lessen that stigma. But nonetheless, these are all on the rise with what's going on currently. So this is an interesting slide, and I've seen this used for other things too, but when we look at the state of Montana, this just kind of gives us a perspective of how big it is. So when we look at 9 East Coast states that have a population of 50 million people, we can fit all of those states within our state, and we only have a population of 1 million. When we talk about distances, and I think this is as a bird flies, the distance between Troy to Baker is 746 miles. We can travel from Washington, D.C. to Chicago, and it's 701 miles. So moving in, and the things that you're going to see on these next slides, there's comparisons from Montana versus national, and then we'll also look at some different demographic comparisons. So when we look at the 5-year suicide rates between 2012 and, 2016, Montana males we're seeing at 37.3, whereas US males are at 20.72. So it's not double, but it is almost double. And the same with females, 10.9 for Montana, whereas it's only 5.74 for the nation.
Can I quickly ask, is that, say, 37.3 per 100,000?
I think that's what it is. I was like, oh gosh, I got a statistician on here. He's going to ask me a question. I will go back, Casey, and double check the data that this comes from and confirm that what I'm telling you is correct. Because
it seems natural that would be per, say, 100,000 or per some number.
Yeah, because I think, let me go back here real quick. I'll come back down here. This slide earlier here. Yeah. So this slide at the beginning where we talked about there were 14.5 per 100,000 would make sense to be compared here. Yeah, there's the 14.66. Mm-hmm. So this is over 5 years, so the number looks a little bit different, but yeah. Does that make sense? I hope it makes sense. I'm not really
no, that's exactly what I expected.
But I know you are, so if you have questions, let me know. And then when we look at race, again, noting that we have a higher population of American Indians in the state of Montana, we're seeing a way higher rate of suicide in our state, even in comparison to Native Americans that live outside of Montana. And obviously, we're still seeing that increase with people who are white in Montana versus the nation. So when we look at marital status, that also seems to be sort of a factor, I guess. So for people that are divorced, we see a higher rate of suicide versus people who are married, which are in the green bar there, the smallest portion. Single, never married is in the second, and then widowed is the third. And I think this plays into what some of you have stated earlier, in that isolation, not feeling like you have support, or feeling like you have to ask someone for that, whereas a person who's married, has more access probably to a person to be helpful with them, or to even notice. I think that's the other thing we think about. A person who lives with you, sees you every day, is going to notice some of those changes, whereas those might go unnoticed in other settings. We also see some changes in terms of educational attainment. So basically, the more education you have, the lower rates of suicide that we are seeing. And I think we can talk about that in a lot of different ways. What are some thoughts that you guys have about why that might be?
This is Lisa, and I think that I was just going to put it in the chat, but we look at their levels of education, but I always connect that with levels of poverty, because people who have less than a high school education are most likely living in poverty, which they're just less financially stable and probably don't know how to access help.
Absolutely. Yeah. And I would even say, to add on to that, Lisa, is that it makes more sense that you're going to have better access to care, whether that is because you have insurance, or you have more ability to pay for those kinds of things. I think we also know that people with higher levels of education tend to be a little bit more aware of resources in those areas. I think most of us on this call, not all of us, but most of us either work here at the college or in the K through 12 system. I mean, we have EAP programs where you can go to your first 4 sessions of therapy for free. So some of those things that are really sort of encouraged and marketed are not going to be happening in some of the jobs where, people have less education. I also see that sense of purpose, more financial stability mentioned from people. Absolutely. And as we go and talk more about some of the risk factors, that plays into that. If I have a higher level of education, I probably have a more professional position where I feel like, I really have a purpose, and I have meaning that is garnered from that, where that might not be as likely for a person that is in a position with less education.
I would also say that I think the higher the education you have, the more stamina you have to solve problems. That
Yeah.
when you don't necessarily have an immediate answer to something, that you're more willing to take another stab at it and another, which we all know you have to do to solve problems many times.
Absolutely. And I think that you make a good point, because the other thing I think about, we work a lot in counseling, is doing that comparison factor of like, when was another time when something was hard and how did you get through that? With working through, getting higher levels of education, you've probably had some some failures and some successes that you can reflect off of as well. So yeah, when we look at suicide rates, this one is looking at age groups. And I think obviously we can see those middle age groups is where it's higher, and we can make a lot of predictions about those kinds of things as well. But there's a lot of life changes that happen in those in that area, whether that be marriages, divorces, having children, losing jobs, all kinds of things that happen in that age of development that might lead to that. The other thing I think from a mental health perspective is to think about, when the onset of things like depression happen for people. And it is usually in those, the 20s often. And it takes a long time for people to get diagnosed sometimes. And so I feel like that's a factor too. I don't think people.
I was thinking, this is Lisa, when I, that's kind of the age group that I teach, that, the lower teens, that a lot of them are coming to terms with their sexuality at that point. And I connect some of those rates with that confusion, not being accepted by peers or whatever. That's just what I'm thinking.
Yeah, absolutely. And I think we'll see, I don't know, I don't think I have a slide specifically on that, but, the Trevor Project, which some of you may have heard of, is really doing, I think, a lot. And I have a slide at the end when I talk about resources to sort of help people through that. There was that campaign of It Gets Better and some of those kinds of things that I think is really hard. I work here with college students, which they don't like to hear this, but I'm like, you're still developmentally an adolescent, and that thinking that we have during those ages, we don't have a lot of comparison to be like to compare getting through hard times, or when we have a breakup with a significant other, if that's the first time that we've ever gone through that, it can feel horrible, like the worst thing that we've ever experienced, because it probably is. As we get older, we have gained a little bit more perspective about some of those things sometimes. So yeah, and then especially like you're talking about, if I don't have support, if I don't know people like me, or if I don't feel like there are people who are accepting of me, it's a really lonely path. And good for us to pay awareness to when we think about the LGBTQ youth. So when we look at mechanism, which is always something I don't really like to talk about, but I think that is important when we consider our state. As I mentioned before, 62% of suicides during those years occurred by firearm. The second most common mechanism is hanging, strangulation, or suffocation. Drug poisoning, which did not include alcohol, is next. And then sort of other or unspecified, and the lowest number there is poisoning. So that could be gases, vapor, carbon monoxide poisoning, those kinds of things. Whoops. So some of you might be familiar with this, but the Youth Risk Behavior Survey is data that our state has collected for a long time. So the next few slides kind of talk about that in relation to what we see with our youth. So during, the question was asked during the past 12 months about whether or not they had attempted suicide one or more times. And in our students in Montana high schools, we're seeing them at about 10% are answering that was true for them. The next bars show just kind of the differentiation between males and females, what grade levels we're seeing that at, and then what I indicated earlier is that people from non-white races were seeing higher rates of that. There are lots of things connected to that we've been talking about. We also saw that 15.6% of 7th to 8th graders have indicated that they had attempted suicide in the past 12 months, and more than 3,300 12 and 13-year-olds. One of the things that I think is important to point out here is this is an assessment that they're filling out themselves, and I think that we could probably make some argument of, that wouldn't have really done anything to them or those kinds of things. I've definitely met with clients who have told me that, they took 5, Benadryl or something and hoped that they wouldn't wake up. And I don't think to focus on what they did or how they did it as important as thinking about the fact that in their minds, whatever they were doing was a suicide attempt. Like they did that with the hope that they wouldn't wake up or that it would work or they wouldn't, have to be here tomorrow, those kinds of things. And so, some people might kind of dismiss this data, but I think it's indicative of really the way that these people are feeling, and it's still important for us to pay attention to. So when we look at Montana high school students, those who had attempted suicide are more likely than those who had not attempted suicide to have the following things. So they are more likely to have driven when they were drinking alcohol during the past 30 days. So 15% versus 6%. That they are more likely to have been physically forced to have sexual intercourse when they didn't want to. 31% of students who had attempted suicide versus the 7% who had not. They're more likely to have been bullied on school property within the last year. And they are also more likely to have not gone to school because they felt unsafe. And that can be for a variety of reasons, but I think this gives us, again, some more data to just think about what it's like for a youth, like what kind of behaviors are they exhibiting, and what kind of situations have they been in that might be leading to the way that they're feeling. We also see that those who have attempted suicide were more likely than the ones who had not attempted suicide to have been electronically bullied within the past 12 months, at almost 3 times the rate, to have smoked a cigarette during the past 30 days, again, almost 3 times the rate, and to have used marijuana within the past 30 days, to have ever taken a prescription pain medication without a doctor's prescription. And I think all of those are a little bit indicative of what they might be doing to kind of self-medicate or cope. Not healthy mechanisms, obviously, but are there nonetheless. The other thing that we see is there's almost a 380% increase in suicidal ideation for students who are getting Ds versus those who are getting As. And again, when we talk about perspectives for adolescents, I think that this comes in a lot. My youngest brother's best friend took his life his sophomore year of high school the day before grades came home. And I think about, to him, I'm sure in his mind he was feeling like he had let his parents down and all kinds of things. But in the grand scheme of things, had he been able to share that with somebody, hopefully they could have gotten him some help and realized that wasn't something that his parents and him could not have worked out. It's just devastating. So when we talk about survivors of suicide, I think sometimes that can get misconstrued. A survivor of suicide isn't a person who attempted suicide and wasn't successful. A survivor of suicide is when there is a suicide, the people that are left, that are, kind of here dealing with the aftermath. So studies have shown that for every completed suicide, there are 147 survivors, or 147 people who've been exposed to that. Among those, more than 6 experienced a major life disruption. And we know that people who have been a survivor of someone else's suicide then become 3 times at the risk of suicide. We see this, we talk about contagion effect. Some of you may have heard of that around suicide, and we saw that, unfortunately, here around Havre last summer. Fort Belknap had a lot of suicides over the summer, and it was very much this contagion effect of people who had lost multiple family members and friends from suicide and were just in that deep, dark place where they decided to take their own life. It was large enough at the time that their tribal leaders actually declared the suicides a pandemic. I don't know if all of you were here to be part of that, but it was very sad. Okay, look, I'm missing the chat. Sorry, let me go back and read these messages. Are you concerned with an upward trend due to the lack of socialization? Yes. So Jared is asking about an upward trend of socializing with peers and direct contact with their educators due to remote learning and isolating. I think that it's not something that can't be overcome, but I think it's definitely something for us to pay attention to. I mean, developmentally, when we think about what is, especially those adolescents and their identity formation stages, and what is so important to them at that age is to have connection with their peers. And so many of them are not getting that. And if we're not paying attention to some of those things, I think that there are really some concerns. I know I talked with a mom yesterday whose youngest kid is now in quarantine, and she was like, "Oh, I let him have a friend spend the night last night," and and so it's like, you get to this place where you're having to weigh. I think sometimes, the COVID risk, for instance, versus allowing your child to have social time, and the other thing that I think. This doesn't so much have to do with suicide, but we've seen a tremendous decrease in the amount of calls that have gone into child protective services because, abuse is typically happening at home, and those things are seen by school staff. And if they're not there to be able to see those things, then they're not able to make those phone calls. And so it's another thing that I think we're seeing, and an increase in domestic violence as well around this. So I think hopefully you guys will feel like you get some stuff out of this presentation that will help you, think about these things and know, be more aware of some of the risk factors and those kinds of things to assess for that. But absolutely, I think we are only beginning to see some of the outcomes of that. I've definitely have been hearing data that the calls into, for instance, crisis support networks and that kind of thing has gone up considerably since last March, and that we are hearing about increases in suicidal ideation. I haven't seen data that has said that our suicide rates are actually up, but I think it's concerning nonetheless. When thoughts are there, there are probably behaviors. So when we look at people who complete suicide, we know that about 90% of them are suffering from at least one major psychiatric disorder. Mood disorders are the most prevalent at 49 to 64%. And mood disorders are things like major depressive disorder, bipolar disorder, those that come often with depression. The second most frequent diagnosis is a substance abuse disorder. But I think it's also important to point out that not all mentally ill people attempt suicide, and there certainly are people who have attempted suicide that don't meet the diagnostic criteria for a mental health or a substance abuse disorder. So in Montana, when we look at this data, I don't know what year this was, but based on the 313 suicides that provided mental health information, we saw that about 83% of those had mental health issues, which is obviously higher than what we're seeing nationally, and that only 17% reported that there hadn't been a mental health issue. And in Montana, when we look at the prevalence amongst the different mental health disorders, my chat box is in the way here. We can see that about 21% had multiple mental health disorders, or sorry, 21% had multiple mental health disorders. Obviously, we're seeing a higher frequency of depression, 69%, 8% bipolar, 8% PTSD, 3% psychotic disorder, 7% anxiety, and about 5% that we were seeing outside of those. But it is really common for people to have more than one mental health diagnosis. I feel like I can't say this enough. We know that depression is treatable. In fact, it's one of the most treatable of all of the psychiatric disorders for young people. When people engage in a combination of both talk therapy as well as a medication, we have about an 86% success rate with treating that. And this is kind of a big gap, but we see less success when they're only engaging in one or the other. So if they're only taking a medication or they're only doing therapy, the success rate is between 40 and 70%. Depression affects 21 million Americans each year, and as many as 1 in 33 children and 1 in 8 adolescents have clinical depression. Even though those numbers are so staggering high, only 10% of those people ever receive any kind of treatment. And as I stated before, most that are diagnosed with major depression are receiving a diagnosis between their late 20s to their mid 30s, but that doesn't mean that that is the first time that they're exhibiting symptoms. I know as a provider, oftentimes I'll have people say, well, I didn't get diagnosed until this age, but I actually have been feeling this way since I was 13 or something like that. So. And this isn't just an American problem. By the year 2030, depression will be the most common health problem in the world, according to the World Health Organization. One of the things that we also know about depression is it tends to weaken our immune systems, and it makes people with depression's bodies more susceptible to other medical illnesses. They're 4 times as likely to develop a heart attack, for instance, than those who live without a history of the illness. So there are 3 special groups of concern, 2 of which we've talked about, but the other one is successful people. Let's talk a little bit about that. So when we think about those groups of concern, what are your guys' thoughts about why successful people, whether that be adults or adolescents, might be a group that we need to be concerned about in terms of depression and suicide?
Pressure people put on themselves that it's not good enough ever, or striving to do more.
Yeah, lots of pressure. Sometimes that's on themselves. Sometimes that's outside. You know, it could be parental or supervisors or that kind of thing. That perfectionistic attitude sometimes of things can't be less than 100%. Wanting to be perfect, pressures to maintain that success. Yeah, feeling like, you know, again, when we talked about on that one slide that talked about not wanting to be a burden, you know, successful people a lot of times will give you answers like, I should be able to figure this out, or I shouldn't be this way, those kinds of things, and really maybe feeling like they might be letting people down to be less than perfect. The other thing is, you know, if that success comes with a lot of stress, that certainly can affect, you know, the way our body is processing, the way that our thoughts are, and our emotional states, and our sleep, and all kinds of things. So just because people are successful doesn't mean that we should be overlooking them in terms of potentially having some risk factors.
I read a thing too about this. Some writer was calling it the imposter syndrome. Like, it's just a matter of time before someone figures out that I'm not really this smart, and I'm not really this organized, and I'm not really this good at what I'm doing. And that kind of pressure that someone would put on themselves.
Absolutely. And I think that ties a lot to the identity that we were talking about earlier. So if your identity is really tied to that, and then that is potentially at risk, then what does that mean about, you know, who you are and all of those kinds of things. Yeah. Not wanting to be perceived as weak can be another thing too. Like I'm strong, I'm smart, I can figure this out. I don't need other people's help. Yeah. So one of the things, I think this is something that we don't often talk about either. And I think it's important for us to keep this in the back of our mind as we think about treatment for depression. So we know that people don't recover overnight. People come out of that desire to kill themselves slowly. Sometimes we will see that their affect is brighter, and we might get this false perception of, oh, they're not thinking that way or they're not feeling those things anymore. But sometimes that brighter affect is really indicative that they've made their mind up and that they can finally, see an end to their pain and anguish, or that it's finally going to be over. I know this was something when I was in my clinical internship, we talked a lot about, like, when we saw people who had been really, really depressed and all of a sudden they're all better. It's like, oh, we really need to narrow in and make sure that we're really attending to them, because that could be what is happening for them. So oftentimes, people get depressed, they might have suicidal ideation. We get them, parents or friends or family members or whoever is getting them into inpatient treatment. And naturally, the tendency is to think when they get back that they're going to be better. But what we know is that the greatest risk is not when people are in the depths of their depression, but during the first 90 days after that depression begins to lift. And in fact, we see that suicidal thoughts and attempts are 4 times more likely during the first 10 days of treatment than after 3 months. And that the highest rate of suicide is not while a person is in inpatient treatment, but it's actually the first 30 days after they've been discharged. And so these are, I had a phone call this morning of one of my clients that's being discharged, and they wanted to make sure that they had an appointment with me like today or tomorrow, because sometimes that happens. They discharge people without connecting them to resources in their community, and those things go overlooked. So important to keep those things in mind. So warning signs of suicide. I have a really hard time with this acronym, but I think it's good information nonetheless. I can never remember what it stands for, but so the mnemonic is path warm, and thinking about warning signs of suicide. So the I stands for ideation. So has this person expressed or communicated ideation or thoughts about wanting to hurt themselves or kill themselves? Have they been talking about wanting to or looking for ways? Have you noticed they've been seeking access to, whether that be firearms or pills or other means, that they've been talking or writing about death, dying, or suicide? And it's important to remember that this is when those actions are out of the ordinary. So a person that's always, kind of been infatuated with, death or something like that, and that's just kind of normal for them, we wouldn't be as concerned with that as when it's a change in their thought patterns or a change in their behaviors. The S stands for substance abuse. So anytime we're seeing an increase in alcohol or drug use, that might be a red flag for us in terms of thinking about suicide. The P stands for purposelessness, and we've talked about that quite a bit today. So when we have people expressing not having a reason for living, not having a sense of purpose in their life, when they start giving things away. Also, a lot of times we'll see a real decrease in their hygiene, that there's just not any reason to keep that up or maintain that. Anxiety. So when we notice that people are anxious, agitated, they're not sleeping, or they're sleeping all the time, difficulty concentrating. If they're feeling trapped, sometimes people will indicate that there's no way out, things are never going to get better. We'll talk about this in a minute or so, but things like when people have lost a job or lost a lot of money or those kinds of things, like there's probably a real sense of feeling trapped in those things. Having some hopelessness. Again, we talked about this with college students, but like when there isn't future orientation, when they're not even able to think about, next week, next month, next year. If we see withdrawal in terms of social isolation, when they start pulling away from friends, family, society, not wanting to do things that they used to find engaging and exciting, those kinds of things. Anger is another one. Rage, uncontrolled anger, seeking revenge, being really irritable. When there is recklessness. So sometimes we'll see people engage in really high-risk activities that might seem like they're not thinking things all the way through, being really impulsive, especially when we see that in younger people. I personally think a lot of young people act like that a lot of times, so that might be a little bit hard to differentiate, but if it's out of the ordinary, if those are behaviors that they wouldn't usually engage in, I think that's a red flag. And then when we see dramatic mood changes, sometimes a flat affect, meaning that they're just like not a lot of facial expressions, they're not expressing a lot of emotion. If there's depressed mood or just kind of in general acting out of character. So when we talk about the keys in terms of assessing the degree of risk, we want to remember not to hesitate to bring up the word suicide. I think there's a common myth that asking them if they're suicidal will plant the idea in their mind. There's no research to support that whatsoever, and actually being direct can validate their pain and give them an opportunity to talk. When we talk about ambivalence, if a person does have a suicide plan, it's important to determine the seriousness of risk. I probably should have talked about ambivalence a little bit more there. Whoops. So ambivalence, I think, and this is hard for me sometimes even as a mental health professional, but people will talk about sometimes like, sometimes I have these thoughts, that it'd be easier if I wasn't here, or, sometimes I just wish I would wake up or I wouldn't wake up, or some of those kinds of things. When I go into sort of assessing that more deeply, well, have you thought about that? Do you have a plan? Do you have access to those things? Kind of that direction of conversation is no, that they just kind of have those thoughts in their head. And not to be dismissive of that, but those aren't as concerning as when a person has developed a plan. And so that's what we'll talk about next. So when we talk about how serious that risk is, it's important to think about the specificity. Do they have details about the plan? Have they researched it? Are they telling you about a specific place they're going to go, or a specific day, or those kinds of things? It's important to assess the level of lethality in the proposed method. As I discussed earlier, sometimes people don't have a real good idea about, for instance, the amount of pills that it will take to overdose, but that certainly is something I've had clients tell me that they've Google searched. So, making sure you're sort of assessing that. And do they have availability of that? I've had, for instance, students tell me that they, fantasize about driving their car into off a bridge or something, but they're from out of state and they don't have a car here. Not having access to firearms. I had a student in my office earlier this semester that had been having some suicidal ideation, and he has a friend keeping all of his firearms. So he knows that right now when he's trying to get help, he doesn't have availability to those things, and trust that friend will keep them for him. What's the proximity of helping resources? Do they have someone that is there for them? Do they have a mental health provider? Do they have access to, check into an emergency room or something like that if they feel like they can't keep themselves safe? We also want to look at the dangerousness. So the greater the dangerous. Okay, so I skipped this. The strongest behavioral warning is an attempted suicide, and we talk about that a lot in our field. If a person has a history of suicide attempts, everything that allude to and talk about in terms of suicide, we will treat that much more seriously, just because we know that they've tried to go through with it before. So one of the things that we assess is the dangerousness of that previous attempt. Like, did they take 5 pills? Did they take 20 pills? And really, I think that gives us some indication of kind of what they're willing to do. And then the intent of their behavior. I have definitely had people tell me, like, right after I took them, I knew I didn't want to die and I made myself throw up. Or were they really disappointed? I've had students tell me that too. I woke up and I was mad that it hadn't worked. I was really hoping it would be over, or that kind of thing. So that intent, I think, is really important to look at. The timing. So another interesting thing to think about is that the more recent the attempt, the higher level of their risk. So if they indicate that they had a suicide attempt, but it was when they were like 13 and they're now 25, that's not as high of a risk than if they told you it was just 2 weeks ago. And did they tell anyone that they had made an attempt? Did they leave a note? Those kinds of things. I think that's can help you think about that risk a little bit too. We know that in over 70% of successful suicides, the person did give some type of warning. So in the state of Montana, 74% of the suicides where warning signs were identified, at least there were at least 3. I had a question a couple presentations ago about how this information is gleaned. And basically, Carl Roston has, every Friday, he reviews death certificates. And if suicide is that question, he conducts interviews and all kinds of things. He'll review people's medical history, all kinds of things in order to kind of gather more information about this. So only 26% of the time were there no warning signs at all. So as we mentioned before, previous suicide attempt is definitely a risk factor. Mental disorders are a risk factor. If they have both a mental health and a substance abuse disorder, that is a risk factor. If there's any family history of suicide, a sense of hopelessness. If the person is more prone to impulsive or aggressive kind of tendencies, if there are barriers for them in accessing mental health or substance abuse treatment, if there has been any losses in terms of relationships, social work, or finances. Chronic pain, we talked about that earlier. If they have easy access to lethal methods, especially if that is a firearm. If they're unwilling to seek help because of the stigma attached, some of the things that we talked about earlier, like not wanting to be perceived as weak or needing to think that I need to do this by myself, those kinds of things, that is a risk factor. The influence of significant people can be a risk factor, whether that be family members, celebrities, peers who have died by suicide, direct personal contact, or inappropriate media representations. But there are also things that can be protective factors. So when we have effective and appropriate clinical care, whether that be for our mental, physical, or substance abuse disorders, if there's easy access to a variety of clinical interventions and support for help seeking, sometimes in some of our smaller communities, there might be only 2 providers and that person's already seen 2 of them and they don't click with either one of them. Places where there is more variety to the kind of help that they would get can be a protective factor. When there are restricted access to highly lethal methods of suicide, could be a protective factor. I know at larger universities, like when I was working at MSU Bozeman, where they have a university police force, that was one of the things that we were able to do is have the university police come to a student's home, with their permission to take their firearms or rope or whatever it might be that they had in their home and keep it with them until their counselor or psychologist felt like they were no longer at risk. Additional protective factors, obviously, if we have family or community support, If there's support from medical, mental health, or substance abuse, and those are caring relationships, those are a protective factor. Cultural and religious beliefs can certainly be a protective factor as long as those are discouraging to suicide and kind of supporting of those self-preservation instincts. And I can't remember who mentioned this earlier, but if we have learned skills in problem solving, conflict resolution, and nonviolent handling of disputes, that is a protective factor as well. I think we were talking about this in relation to education level. So now I'm going to move on to the QPR part, and I'm trying to be mindful of time, so I might go through this a little bit quickly, but QPR stands for question, persuade, and refer. It is not intended to be a form of counseling or treatment, but it is intended to offer hope through positive action. So when we talk about myths and facts of suicide, a myth, no one can stop a suicide, it's inevitable. When in fact we know in a crisis if people get the help that they need, they often are never going to be suicidal again. Confronting a person about suicide will only make them angry and increase their risk. We know asking someone directly about suicidal intent actually lowers their anxiety. It opens up that communication and it lowers their risk of an impulsive act. Only experts can prevent suicide. Suicide prevention is everybody's business and anyone can prevent the tragedy of suicide. And I would say, as a mental health provider, I know that not everybody's going to come to me. And in fact, a lot of people won't. And so this is why it's important for us to all have this knowledge. And so I thank you all for coming today. Suicidal people keep their plans to themselves. As we've stated before, most suicidal people do communicate their intent sometime during the week preceding their attempt. Those who talk about suicide don't do it. We know that people who talk about it might try or even complete that act. Once a person decides to complete suicide, there is nothing anyone can do to stop them. In actuality, we know that it's one of the most preventable kinds of death, and that almost any positive action can help save their life. So the more clues and signs that are observed, the greater the risks. And as I stated earlier, we need to make sure that we're taking all signs seriously. Sometimes people are really direct in the way that they communicate and how they talk about things. So they might say things like, I've decided to kill myself. I wish I were dead. I'm going to commit suicide. I'm going to end it all. If such and such doesn't happen, I'll kill myself. But sometimes people are more indirect, like I'm just tired of life. I can't go on. My family would be better off without me. Who cares if I'm dead anyway? I want out. I won't be around much longer. Pretty soon you won't have to worry about me. Sometimes we'll see things in their behavior, as we mentioned before, if there was any previous suicide attempt, if they are working on acquiring a firearm, or if they've been kind of stockpiling pills. I think this is one that is concerning when a person has depression, anxiety, that kind of thing, and they've been picking up their medications, but they haven't been taking them. It could be an indication that they're kind of saving them up for something. Also, when we see co-occurring depression, moodiness, hopelessness, when they seem to be putting their personal affairs in order or giving things away, if they have a sudden interest or disinterest in religion, if there is drug or alcohol abuse or relapse after a period of recovery. And again, that kind of ties into that feeling like you're a failure, that kind of thing. I've really seen people struggle after they've been sober for a while and then have relapsed. Also, if we have unexplained anger, aggression, irritability, that might be some clues as well. So situationally, if we know someone's recently been fired or is being expelled from school, if they had a recent unwanted move, if there was a loss of any major relationship, if there was a death of a spouse, a child, a best friend, especially if that death was by suicide, if they've been diagnosed with a serious or terminal illness. And honestly, I think that's very much tied to why we see the rates of suicide that we do in our elderly population. Mm-hmm. If there is a sudden unexpected loss of freedom or a fear of punishment, like they know they're going to jail or they know they're going to be found out about something. If there's an anticipated loss of their financial security, the loss of a cherished therapist, counselor, or teacher, can also be a really big thing. And I've seen quite a few students here at the college who, lost a coach or lost a teacher or something like that in high school. And it's a struggle for them, especially if that person was the one that they counted on as their adult to go to with problems and concerns. And also that fear of becoming a burden to others. And that can be very tied into some of those other things like the loss of financial security, the serious and terminal illness, those kinds of things. So in terms of asking the suicide question, if in doubt, don't wait, ask the question. If the person is reluctant, be persistent. It's helpful if you're able to talk to that person alone in a private setting, and allowing them to talk freely. Make sure that we're giving ourselves plenty of time to have that conversation, and have your resources handy. So I believe that because this is a virtual training, your QPR card will be downloadable for you on the QPR website. And that is something that you could keep on your phone or something like that. It is really kind of a helpful booklet to go back. It gives you things that suggestions of things that you can say and that kind of thing, because it might be a while before you're having to use these skills, and if you're like me, you probably have forgotten by then. So I think that QPR card can be really handy. Having phone numbers, if you know that person's counselor, having their name and any other information that you think might be helpful. So a less direct approach might be things like, have you been unhappy lately? Did I skip a slide? No. Have you been very unhappy lately? Have you been so very unhappy that you've been wanting, or you've been thinking about ending your life? Do you ever wish you could go to sleep and not wake up? Whereas a direct approach would be, when people are as upset as you seem to be, they sometimes wish they were dead. I'm wondering if you're feeling that way too. You look pretty miserable. I wonder if you're thinking about suicide. Are you thinking about killing yourself? And if these questions are too hard for you to ask, finding someone who can help you with that. We don't want to say things like, you're not thinking of killing yourself, are you? Or you wouldn't do anything stupid, would you? Or suicide is a dumb idea. Surely you're not thinking about suicide. I think often when people ask these questions, their hope is, gosh, I hope that person doesn't say anything, because I surely don't want to have this conversation with them. And so this shuts the conversation down, and then you're kind of protecting yourself rather than helping that other person. Whoops. Instead, we want to be able to listen to them. We want to give them our full attention. We want to remember that suicide isn't the problem. It's only their solution to a perceived I keep forgetting to fix this slide. Insolvable problem. We don't want to rush to judgment, and we want to be able to offer them hope in whatever form that could be. Then we want to ask them, will you go with me to get help? Will you let me help you get help? Will you promise me not to kill yourself until we found some help? And I know those are really direct. That last question in particular is very direct, but I feel like I think that expresses concern for that person and also gets them, like, I'm not going to give up on you. I'm going to be here until we get you what you need. We know that our willingness to listen and help can rekindle that hope and make all the difference for that person that's feeling really, really lost and hopeless. So our next step is the refer. So suicidal people often believe they can't be helped, so we may have to do more. The best referral involves actually taking that person directly to someone who can help. And I would encourage you, if that is possible for you, to do that approach. The next best referral is getting a commitment from them to accept help and then making the arrangements for them. So that might be, calling someone, setting up an appointment, that kind of thing. The third best referral is to give referral information and try to get a good faith commitment from them that they won't complete or attempt suicide. And knowing that a willingness to accept help at some time, even if it's in the future, is a good outcome. Since almost all efforts to persuade someone to live instead of attempt suicide will be met with agreement and relief, don't hesitate to get involved or to take the lead. Things like, I want you to live, or I'm on your side, we'll get through this, can be very effective. It also might be helpful to ask the person who else might help them. Like, can I call somebody, your roommate, your parents, your boyfriend, a religious person. to help you with that. And selfishly, I feel like I do this sometimes, even as a mental health provider, because I feel like it helps me feel like I'm on a team of other people that are all trying to help this person. Like, I can't go home with them, I can't follow them, but I know that when they get home, they have a person who is, on board with helping keeping them safe. What do you do if they refuse to see a counselor, even if you set it up and say you'll go with them? I think this is really up to you, Sonia, and I think it has a lot to do with the relationship that you have with that person and what other things you might be able to bring into the equation. So, sometimes you're not the best person in terms of maybe you don't have a really trusting relationship with them, or that they don't feel comfortable necessarily talking with you or something like that. And so to try and get someone that can do that more, I think you certainly, you guys, no one on this call I don't think is a counselor, so you guys aren't bound by confidentiality. So you could breach that, if you could be sort of threatening about it, I guess, in terms of, if you are not allowing me to go with you, I'm going to find somebody else who will take you there. I mean, I guess that's not really threatening, but it's putting in something else in the equation. I've had to do this with a lot of people in terms of just having to talk with them for a while until I could get them on board with me. Yeah. And sometimes I think there is a fear, and this might be the case, Sonia, if this was, I don't know how old your daughter is, but they don't know what's going to happen. Okay, so what if I do go to the counselor? What if I do go to the ER? What's going to happen there? And I think that's where, people like me or somebody else might be able to give them those expectations of what to expect, because it's kind of scary. Like, they don't know. I had a student come in here yesterday that was referred by one of her professors, and I think she thought that when she got here, her professor was going to have already talked to me, and I hadn't talked to the professor, so I had no idea what she was coming in for. And she didn't, by the end of the session, she decided she didn't want to see me, that she was going to go back to a therapist that she'd seen for 2 years, which was fine. But in the midst of all of that, we had a lot of conversations about how I could be helpful for her on campus and those kinds of things. And so I think relationship building and rapport building and building that trust sometimes is important. And I think, Sonia, if I was in your shoes or your daughter's shoes, really utilizing my assessment of what risk that person was at might make me decide what I was going to do. Like, if I really could trust that their risk wasn't really high, or the plan that they had made wasn't really lethal. But if I'm feeling like, I was in session with a kid one time who had a switchblade in his pocket, and I could hear him opening it and closing it. And he told me when he left session with me that he was going to go slit his wrists. I called the cops. He clearly wanted help because he allowed me to follow him out to his vehicle. I got a description of his vehicle. I got his license plate number, and I was able to give that to the sheriff's department. And when I called in, they were familiar with him, and they, were able to find him and get him back into Warm Springs, which is where he needed to be. But we can't help everybody, but I think as much help as we can do, and to reach out to other people who might be able to problem solve with us sometimes can be helpful, so that we don't feel like we have to be doing that all on our own. I don't know if other people have suggestions. Feel free to jump in if you want to. So this next part is really kind of what I've alluded to in terms of getting a team, so that if you have clergy, therapist, psychiatrist, or whoever is going to be providing that treatment and you're on board with that, that can be really helpful. Sorry, I'm going over, huh? What time is it? 12:56. Sorry, Nancy. I'll if you guys need to hop off at 1 o'clock, I'll give you the link to the role plays that we'll go through. You want to be sure to follow up with a visit or a phone call or a card, whatever feels comfortable, letting that person know you care about what happens to them. I think those are really important too. I get sometimes as a counselor, well, this is just your job. You don't really care about me. So being able to execute that in whatever way you can. Remember, when we apply QPR, we plant the seeds of hope, and the hope is what helps us prevent suicide. So I'm going to go through these super quickly because I know I'm running out of time here. So this is other programs that are out there. So QPR is supposed to be 2 hours. I feel like that's a lot sometimes, so I try to squeeze in 90 minutes and I don't always get there. Assist is another workshop. It's actually 2 full days of working with suicide prevention. I have not had that training, but we do have 2 faculty members on our campus that are trained in that. Mental health first aid is another one that is getting a lot of publicity lately. It is a program that helps the public understand all mental health disorders and be able to respond to those mental illnesses and substance use disorders. And there is a short portion of that is on suicide. They also have developed one that's youth mental health first aid, so that is more appropriate for adolescents. If any of these programs are things that you're interested in, be sure to email me and I can get you in contact with the facilitators or trainers of these programs that I'm aware of. Signs of suicide, I'm not super aware of. I don't know that we even have that in our county, but it is a school-based program which tries to raise awareness of suicide within the school system. So I don't know if anybody participates in the state suicide prevention conference, but the one in 2018, we actually covered this. And so the state of Montana paid a couple of people to come in and write this school toolkit on suicide. And this website here at the bottom, it is available for free for any school that wants to download that. There was also a copy, I think, sent to every single school in the state of Montana. But this is really addresses like prevention strategies as well as postvention, like what to do after a suicide has happened, how you would respond to that within your school system. Crisis intervention training is a training that we do with law enforcement to help them better understand and manage mental health issues when they are responding to a call. We've had actually pretty good support with that in the state of Montana. We've had a harder time getting our rural officers able to participate in that because they have to take time off and then they have such small forces that they often don't have people to fill in for them. But this is a very well supported program in our state. They've also developed suicide prevention for primary care providers. Again, as we talked about, sometimes people don't come to mental health providers. And so being able to really give those primary care providers the skills to assess for suicide. The Trevor Project, which I mentioned earlier, is the leading national organization for crisis intervention and suicide prevention for LGBTQ people ages 13 to 24. And I added this little statistic in here. 87% of LGBTQ youth felt it was important for them to reach out to a crisis intervention organization that specifically focused on LGBTQ youth. So the fact that this project exists, I think, is awesome. This is a slide that I added specifically for today's talk. So they have a host of resources, all of which are really trying to address the high rate of suicide for LGBTQ youth. So they have a lifeline that's a 24/7 crisis call line. They have Trevor Text, which is your ability to text and then talk with a trained counselor. They also have chat, which you can access through their website and have sort of a live chat with someone. They have Trevor Space, which is sort of like like an online, I don't know if I got the right word, but they're able to get on there and talk to other people that are LGBTQ in a way that's basic. I guess it's kind of like Facebook, but with other people who identify as LGBTQ. They have a tremendous amount of research and advocacy and education, just continuing to provide statistics and information that can kind of help us in terms of how we advocate for LGBTQ youth and policies and all of those kinds of things. The data that I talked about today, they do that survey every year, and it's with about 40,000 people. So really a huge research base, which is awesome. I've noticed parentingmontana.org has been getting some like YouTube commercials and stuff like that. There is so much information on this about anything and everything that has to do with parenting, whether it is, around depression and suicide and that kind of thing, or any other things. So this is a really great resource for parents. And yeah, just a lot of information. PAX, the good behavior game, I alluded to a little bit. I know we attempted to start this in our school system last year, and then I don't know, COVID has not been helpful to us in this arena. But the state of Montana used our opioid lawsuit money to fund this for a lot of K through 12 school employees to go through the training. So the intention is that it gets implemented when the kids are in like kindergarten, second grade, and then they build those skills. And the program is usually not used anymore after about 5th grade. But it helps them, learn how to respond to, those negative feelings, negative influences, those kinds of things. And it helps kind of garner positive peer pressure. Helps them with emotion regulation, all kinds of things. And the data behind the good behavior game is phenomenal in terms of what things they're seeing, like more students that go to college, less that are in the prison system, less issues with substance abuse disorders, all kinds of just really great data has come out of this project. I'm not familiar with this at all. But this is really to help psychiatrists in assessing suicide risk. Montana Thrive is a relatively new project. It comes out of MSU Bozeman, and it is a online interactive cognitive behavior therapy program. They've really been trying to target this toward especially males in kind of the farm and ag industry, as we are seeing such a high rate of suicide amongst them, to kind of help them learn some skills and different ways to think about things that in essence will decrease their depression. We also have a firearm safety program in our state. These firearm locks, I think you can get from pretty much any law enforcement agency. We know that 90% of people who attempt suicide and survive do not go on to die by suicide at a later date. And so, if we can just remove that access to them, hopefully we can get them the help that they need. So this, the suicide prevention lifeline is what I was talking about earlier, that they've really seen an increase in usage. And I think especially since they've added their ability to text. So you can now text 741-741 and a crisis counselor will respond to you on text messaging, or you can call them and talk to someone on the phone. So I know I said I'm a little bit over, so I apologize. If you guys have time to stay on, I'd like to run through these role plays. If you don't have time to stay on, that's okay too. If you don't have time to stay on, be sure that you get onto the QPR website and fill out the post survey, and then you'll have an access to your certificate and the card and resources. You will also have access to these role plays that you can do on your own. So I wanted to just kind of go through them. I think I'm going to do this 14-year-old one since we have so many K through 12 staff on here. So I think I need to share a different screen, right? Yep. So when you go in here, and these are still kind of in beta testing, I guess, but I think that they're really great in that you have lots of different options, and then it will tell you in here why the option you picked was good or not good. And so if this is our example, so we're a teacher, a coach, a scoutmaster, an adult responsible for the health and safety of a youth under our supervision. And a 14-year-old boy, Justin, for whom we're responsible, says to us, "This big kid is bullying me. He took me down on the ground and made me eat dirt, and he hurt my arm. I can't stand it anymore. I'd rather be dead than let him catch me again." So if this was the situation, And I'm just going to go through this so that you guys can see how this works, and then I'll send you the link so that you can go through the other one on your own. So our options here are tell me his name and I'll take care of this. So if that was our option, he nods his head in agreement, but says nothing. He seems hesitantly. They changed this since I went through this the last time. So it used to be when you clicked on this, it told you like this wasn't a good answer, go back. Oh, wait, maybe it's just that first question. Okay. So he nods his head in agreement, but says nothing. He seems hesitant. How do you proceed? So do we contact his father by phone and ask him to come to an appointment with us as soon as possible? Do we ask the boy if he has concerns with contacting his father or mother? Or do we take the boy into our office and have him make the phone call to his father and mother and then ask for the phone? You guys have thoughts on this?
I feel like contacting the father and having him contact the father or mother and taking the phone away, those don't seem like very good options.
I'm kind of surprised it gets me this far because really like it was wrong from the first choice that I made, but let's see what this says. I'm kind of upset that they changed this because now I look stupid. So Justin says, can we not do that? My dad gets upset when stuff like this happens, please. So I say, I have to call him about things like this. Okay, sounds like we should talk some more first, or I'm only looking out for your safety. I'm sure your parents will understand. I would probably say this because it gets the kid talking a little bit more. I really kind of liked the way they had this set up before better, but I'm going to see how good I do. If I keep getting correct, then maybe I deserve my master's degree, and if not, maybe not. The goal in all of these scenarios is to keep the person talking, to be open, to keep trying to gather information, to build rapport with the person so that they know you are, you care about them and you're looking to help them, that kind of thing. And so I'm just kind of following that. I would never have picked that first choice at the beginning, so I'm kind of surprised I've gotten this far. So if he ends up saying, I just can't go back there ever, I won't, I'll die first. So this question here, the third option, kind of gives us some an indirect way of sort of asking about suicide. So you know when boys have been bullied, they sometimes believe there's no escape. Are you feeling that way now? So we know that he feels terrified and traumatized. He says, yes, that's exactly how I feel. I can't go back there and I can't even tell my dad. When I told my dad the first time this happened, he told me to double up my fist and hit him in the face as hard as I could. I tried to, and that's why he made me eat dirt and hurt my arm. I would probably go with number 3 on this one. Because again, it's letting you continue to talk. So we're establishing a relationship. We can now go forward with exploring what he means by wishing that he were dead. So, so he says, yes, what ideas do you have? I definitely would go with this. Good, I have some ideas, but before we discuss them, I need you to tell me what you mean by wishing that you were dead. He says, it's just that I can't take it anymore and I won't. I'll kill myself just like my Uncle Jerry did, and I know how. I would probably choose this one. Or it says I could have picked the one before too. Since imitation is a strong human trait and common in suicidal behavior, you'll want to know how his uncle killed himself. So if he says Uncle Jared shot himself in the head with a pistol, he was a veteran and had lots of guns. My dad has them now. So again, I'm assessing for means. So do you have access to any of the guns? He pauses, but then just says yes. So I would say either 1 or 2 would be correct on this one, because we're asking about, this is direct. Are you thinking about killing yourself? This one is more indirect. Are you thinking about hurting yourself? I'd probably do that with the kid. Oh, hurt is not the right verb.